Donc, je vous propose de commencer sur un cas d'un patient donc du service. Je remercie le docteur Roulet qui est interne dans le service d'avoir préparé ce cas. So it's a male, very young, David, 57 years old. Normal BMI, no medical history, is no smoking. He's doing a lot of sport, a lot of climbing, skiing, biking, running, at least 8 hours of sport a week. And he gets an accident during March, last March, and got an ACL, as you can expect. So I saw him in June or July. I mean, not so in June with an MRI, of course, because the patient raised MRI. He came to see me because the radiologist said you get an ACL injury. He's not complaining about anything. He has no pain, no instability, no blocking, no pivot shift, but a positive like test, as you can see, normal range of motion and no muscle inhibition. X-rays. Quite normal, okay? So 57, huh? And he wants to play sport, go back to sport, and I will share with you his MRI. You can see here the slice in the frontal plane, and on the sagittal plane, and so came to see me for an advice. So what do you do? Alan, first, and each of you, what do you say to this patient?
Well, I don't think I've ever been able to do a surgery on someone who's got no symptoms and make them feel any better than they currently are presenting to me. So for me, I treat the patient, I don't treat the imaging. And, you know, if we did an MRI scan of everybody in the room, I'm sure we would find probably 40% of those of us over the age of 45, we would see some degenerative changes in the menisci. So sadly, that is fact. So I would just leave it alone. And only when they presented with symptoms would I counsel them regarding treatment.
Okay, just before going to Fares, what do you say about sport? Do you say, okay, you can go back to sport immediately, Alan, or what do you, because...
Within reason, yeah. I mean, if he wants to go back to do sports, because then if he tests it out and then he becomes symptomatic, then we're in a different scenario if he can't do the things that he wants to do. But currently you're telling me he's got no symptoms, no complaints.
He's just doing biking, but he didn't go back to...
Easiest consultation.
It was his for June, so ski, it was, you know, it's not the ski season. So, Fares, please.
No, I mean, I agree. I think the patient's asymptomatic. At the end of the day, we treat patients, we don't treat scans. So there's going to be an interesting dilemma if you let him go back to sport and then he gets pain and or instability, because then the management, you've got two different issues going on there in terms of instability plus a meniscus that you need to deal with. But that we can come back to when you come to the next page of the story. But for now, the guy's asymptomatic, let him ramp up his sport, and then we'll get to the next chapter.
For me, this is not operative treatment. You should follow up. You should strictly follow up him and see what, after the rehabilitation process that you will give to him to do. And then if the patient remain asymptomatic, he can do some sports after 3-4 months of physical therapy. And if is not able to return to sport, then we can think to do something.
Okay. David?
Eh bien, définitivement pas un traitement chirurgical, mais il y a un élément très important à prendre en compte, c'est que c'est un jeune homme, 57 ans, qui fait du sport et on va lui dire je vais pas vous opérer, et il va penser qu'on l'opère pas parce que il est trop vieux. Alors il faut accompagner ce bonhomme et lui dire non, on va continuer, on va t'emmener faire du sport, mais on va surveiller et on va le rééduquer progressivement, le réévaluer, évaluer son instabilité ou pas, ses douleurs ou pas, pour l'amener là où on veut l'amener sans chirurgie, mais qui ait le sentiment que c'est toujours un sportif et un homme actif.
Okay. Bob, what did you say to this patient? And if the patient is 25 years old, what do you do? Same thing?
So I don't really have much to add as far as the approach to this patient. I think at this point, at least, I certainly think letting him ramp up his activities is fine. I honestly don't know that the age really impacts me in all that much in this way, except for the meniscus tear. I think if it is an acute meniscus tear in a 25-year-old, maybe we have a little bit of a different discussion as far as initial management, but it's still going to be very challenging for me to operate on someone who has absolutely no symptoms whatsoever. I do think it's important, particularly in the 25-year-old, but also in the 57-year-old, that no symptoms also means no big knee effusion, not they're able to do what they want in spite of their knee hurting and swelling. That's not coping with this asymptomatically. It has to be a quiet, calm knee.
So I'm going to push, for example, this patient, 25 years old, some of you try to do ACL repair, because when you do ACL repair, patient has that symptom. You cannot wait to get the patient complain about instability.
Yeah, I think if this patient is 20, go ahead.
Yeah.
I was just going to say, I think if this patient is 25 years old, I'm going to have a discussion with them about what they want to go back to activity-wise. If they do want to go back to some twisting and pivoting type sports, I certainly think the data would suggest that this is someone who's going to do poorly with non-operative management, and particularly in the setting of a meniscus tear that could, if it's a 25-year-old, is likely not the degenerative change like Dr. Getwood was discussing. I think in that situation, I'm going to probably end up offering the patient a surgery, but it's going to be a discussion because I don't think it's necessarily a have to if the patient's telling me they're asymptomatic. But I think in a 25-year-old with an acute meniscus tear and an ACL tear, I'm going to push them strongly towards surgery.
Fares, do you think the meniscus can heal by itself with no surgery?
I don't think the meniscus is going to heal itself, but on an MRI basis without surgery. But if it's asymptomatic, it's asymptomatic. I think it needs to be triggered by something, and then find out if he gets. I think the tricky thing here is if he then develops meniscal symptoms, then you've got that. In my mind, a very simplistic equation. If you're going to repair the meniscus, you need a stable knee. If you're going to trim the meniscus, you're going to make him unstable. So then you're going to have to deal with both things. But given that he's still unstable at the moment, functionally rehabilitate him and see where he gets to. I think if he's 25, it's a much tougher conversation. And I think it'd be a slightly different presentation. You'd probably get him acutely and so on. But in a 25-year-old, particularly someone who's doing a twisting, turning sport, it is a different conversation. But it wouldn't be a meniscal conversation. It'd be a meniscal plus ACL conversation.
Actually, I did exactly the same thing, but the most difficult part for me was to discuss about the radiologist report with the patient, because the radiologist report said, okay, you need to go to see a surgeon, okay, for advice, but maybe you will get some lock knee, so you need surgery because you will have a locking knee. You have the same issue sometime with yeah,
but
discuss the report of someone else.
No, and all our patients have access to all of their reports, so it makes for sometimes a very tricky conversation. But it's also important that our patients recognize that coming to see a surgeon doesn't mean you're going to have an operation. Coming to see a surgeon means you get a surgical opinion. And I think that's often forgotten.
C'est pour ça que c'est bien des fois de regarder l'IRM avec le patient et de la décrire et d'accompagner
mais c'est ce que je fais systématiquement, mais je sais. Oui, tout à fait.
Parce que quand on n'a que des rapports écrits, effectivement, c'est toujours discutable. À partir du moment où le patient regarde l'IRM avec vous, quelque part, il comprend, il va adhérer mieux au traitement.
Le patient est rentré dans la salle de consultation, il dit, en fait, de toute façon, j'arrive, je veux pas être opéré. J'y vais, je vous dis pas que je vous connais pas, je vous ai pas encore vu, donc on va discuter.
Second case, a 33-year-old woman. She's taxi driver. She do ski on a recreational basis, and she used to run. So normal BMI, a little bit maybe overweight, and she had a ski accident in April. She felt a pop in her knee, and she had hemarthrosis, and so she comes to see the surgeon 1 month after the trauma. Physical examination, knee is not so swollen anymore. Full range of motion. She did few session of physiotherapy. So she has still a little bit of inhibition of the quad. And on Lachman test, a soft endpoint with 3 millimeter side-to-side difference. And the jerk test is difficult to make because she's a bit painful still, but seems to be very minimal, maybe a gliding pivot shift. And so it's a low energy trauma during a ski accident. So there's a bone bruise on the plateau. See the ACL seems detached from its femoral insertion with no meniscal injury. And there is a hyper signal of the ACL. So it's a low energy traumatism in a 33-year-old woman, not so sports, she does not practice any high-level pivot contact sport activity, and she just wanted advice from the surgeon. So the radiologist or the GP say, ask the surgeon if you need surgery or not in an acute setting. So what would you advise in this case? Alan, maybe?
The good news for her, there are a number of series in the literature that shows that after post-skiing injury in the relatively acute scenario, they have got a very good propensity for healing. And that healing may not necessarily be anatomic healing, but it certainly can get some scarring back onto the PCL. And they may then not develop significant functional instability. You know, Bob Marks has written a series from HSS on this very topic. So based on her age and activity profile and the fact that she's had a skiing injury and also her clinical examination, yes, she's only 4 weeks out, so I would very much recommend that she try a non-operative period. And non-operative for me does not mean no treatment, it means a rehabilitation program. And my bets are that she will not need surgery. But of course, if she does need surgery, if she becomes functionally unstable, we can then use the canon literature to tell us that actually there's no detrimental effect of having a delayed reconstruction. So we can play with the literature in any way you want, really, to help counsel a patient to get to their best outcome for them. And I think as surgeons, the consultation, you learn very much about your patient sitting in front of you, and you can essentially direct that conversation where you think is best to go based on that relationship that you have.
Okay, thank you. Fares, do you think the same?
That's beautifully summarized. For me, that's the left-hand column that I presented. This is a patient for which the Canon trial is perfect. There are many patients who would never have entered the Canon trial. She probably would have entered it and would have been the right candidate for a good rehab program and then a reevaluation. She's the one where you do the MRI scan again for her anxiety when she comes back asking for it in 3 months or 6 months, and the ACL will look pretty good.
Yes.
Stefano,
I completely agree, and you just have to see back in 3-4 months with the new MRI and see what's going on, but definitely so far is rehabilitation.
David, do you think the same?
Je pense la même chose. En revanche, je demande pas d'une nouvelle IRM parce que l'IRM ne sera pas vraiment informatif pour moi. Mais j'aime ces patients qu'on traite orthopédiquement, sans chirurgie. J'aime bien qu'on leur fasse des tests fonctionnels pour connaître leurs capacités sportives et les autoriser à revenir au sport en étant dans un environnement sécure. Et on peut leur expliquer en disant on va vous suivre comme les gens qu'on opère et on va vous remettre sur le terrain si votre capacité fonctionnelle et musculaire est bonne. Et c'est un bon message à donner.
Quel est ton suivi, David, alors pour ces patients exactement? C'est toi ta chronologie dans...
Eh bien, ces gens à la phase aiguë sont revus à 1 mois et demi. Au bout d'1 mois et demi, on réexamine. On retrouve quand même très souvent de l'acmane retardé, pratiquement une ébauche du ressaut, et même on a donc un taux de cicatrisation qui est pas négligeable. On a une étude prospective en cours là-dessus et qui est extrêmement intéressante, et on est quand même surpris du nombre de cicatrisations. Et aux alentours de 3 mois, on leur fait des tests fonctionnels comme on fait dans les ligaments croisés antérieurs opérés. Et là, on voit bien leur équilibre, leur capacité sportive, et on va pouvoir les remettre, s'ils vont bien, dans la filière toujours orthopédique et conservative. Et s'ils sont pas, et s'ils se sentent instables, alors là, on peut toujours les diriger vers la chirurgie. Donc ils savent que le chemin est ouvert à droite et à gauche, et ils sont en confiance dans la prise en charge.
The good things of this patient is that he has the meniscus intact, and the intact menisci can allow to have a good stability of this knee. And so before going to do surgery for just an isolated ACL in this type of patient, I will wait.
And if you don't ask any MRI, how long do you wait to allow him to resume his sports activity? Does it depend on the functional status during the tests you make? Or do you wait for 3 months, or for example?
Juste un petit commentaire. Moi, j'aurais plus envie de demander une laximétrie plutôt qu'une IRM. Une IRM, c'est une image et ça me donne pas tellement d'informations sur la laxité. I will more ask for laximetry than a new MRI.
Alors, on a l'IRM, figure-toi. 4 mois plus tard, elle revient et so 4 months later, she did not complain about any instability. She feels perfectly well, full range of motion, no AMI, and she has at Lachman test a firm delayed endpoint. So there is still a difference in the side-to-side laxity with the rollimeter. We trust the rollimeter because, as Elvire said just before, we do it ourselves, and we don't trust the telos done by our radiologists because sometimes they're not just in the right profile, so it's impossible. And sometimes even they put in the popliteus, so it doesn't mean anything. But if you have good telos, I think it's reliable. And so we had this control MRI, and as you almost all said, the ACL seems to have healed in a proper position. It's still in hyper signal, but we can see there's continuity in the fiber. And it's not really a surprise because we operate some patient in an acute setting, sometimes very young and sports guy with the ACL that seems to be healed. It's not really functional, but there's a healing potential of the ACL. So, okay.
Can I ask a quick question? If any of the panel are pro ACL repair, and if this patient presented to your clinic and you're pro ACL repair, then maybe this would be the ideal candidate to get in the operating room early and do a repair. Yet, if you don't repair the ACL, she still does well. So, where are we with ACL repair? David?
I would say that you get the same results and you get more money if you do surgery.
I don't do them, I just revise them.
Yeah, I think you hit it on the head. I think this is an ideal patient to do a repair in if you want to take credit for the healing that's already going to happen anyway. But I think for me, I haven't really utilized repair as a main part of my practice, with the exception of the BEAR trial, which we're a center for. So we are looking at that implant as that method of repair. But I don't think in this patient there's a role for a primary repair.
It depends on when you see the patient, because if you see 3 months after the injury, it's already too late for me for a repair procedure.
And do you think there's a place for the brace, Fares? You told about what do you call it? Because in France there's a famous radiologist named Dr. Delin who described a protocol with bracing inflection, and I think you present the same protocol but with another name, English name probably.
That was fascinating. I discovered yesterday that you guys had published the sort of bracing protocol 20 years ago in a journal I had never heard of. And of course the Australians have now grasped it. Honestly, it's interesting, but whether it really does add beyond just a simple non-operative program, I'm uncertain. I think there is, what I was trying to give across is it's popular right now, but there is a morbidity to bracing. Bracing is not entirely benign, particularly if we've got patients non-weight bearing. So I have to say, we haven't embraced it. Forgive the pun.
I think maybe it's a good message for the audience, because we as a surgeon sometimes see patients who had a brace inflection during a few weeks and they came to our clinics with very, very severe AMI. And I'm not sure the brace inflection, it has not been really scientifically proven that it's efficient in order to obtain a healing of the ACL. So maybe we are waiting for the prospective trials and the results, but we don't still have any. So this is a young girl, 20-year-old young student. She plays handball at a competitive level. So she trained 3 or 4 times a week. And she had a trauma in hyperextension 6 weeks ago. and she felt something happening in her knee, but and knee was not really swollen. She does not have any AMI, and at physical examination, very minimal laxity as the case before, 3 mm side-to-side difference, no pivot shift. And when you look at MRI done 2 weeks after the trauma, you see the ACL is just in hypersignal with the bone bruise in the anterior aspect of the tibial plateau. So it's typical of a hyperextension mechanism with the kind of stretching of the ACL, but seems that a lot of fiber are still in continuity. And she comes to your clinics 6 weeks after the trauma, and she had a first opinion. The guy said no surgery. She wants a second opinion because she wants to be operated, because all the girl in her team has been operated for the ACL. She's convinced that she feels her knee is unstable. So how do you manage this case? You think there's a place for surgery?
What about the pivot shift?
Pivot shift is negative.
Not mention it.
Sorry, negative.
So for me, this is similar. We have the bone bruising consistent with a hyperextension injury and not your typical ACL injury. You don't have substantial increased anterior translation. This does look like a bit of a stretch injury to the ACL. I don't know if you can say based on your office exam that she does not have rotational laxity. It's a lot of studies have shown it's very hard to get a pivot shift when the patient's awake. So this patient may or may not have rotational laxity and may or may not feel unstable when she returns to sport. I think the only way to find that out is to treat her non-operatively, progressing as has been discussed, not just a release, but a gradual progression. And if she does feel unstable, then we certainly would be at that point.
But do you think there's a place for surgery in acute setting in, let's say, partial tear in high-level athletes? Because you consider in a 20-year-old athlete who does high activity of pivot cutting activities, the risk to have a second injury is massive, and then the risk to have meniscal injury. It's just a question.
Yeah, I don't, excuse me, I don't know, I'm not aware of a study really looking that clearly shows that there is a high risk of a re-injury with.
We did one actually.
You may have some data I'm not aware of, but go ahead.
We followed 30 patients like her, and with Jean-Marie, with let's say 5 or 6 years follow-up, and in the age and the sport activity were clearly the main factor related to the failure of the conservative treatment. And in this population, when you operate, it's in the global series of 30 patients less than 30-year-old, take their 8 or 9 or 10, and the re-injury rate was 50%, and there were 40% of meniscal injury. So it's just a balance between the risk and the benefits during, I don't say I would operate her, not at all, but it's just what do you say and how do you manage her?
I think it's a good question. I don't know how much of an ACL tear there is here at all. I think if you have a partial tear is not a partial tear, I think, in all cases. And I think to me, this looks like a strain of the ACL. I see some increased signal. I don't see a clear tear of any bundle. I'll have to look at the axials to get a little better look, but I don't, I think in this case, you could obviously talk about the risks and benefits. You always want to make patients aware that they certainly have an increased risk of a meniscus tear if they do have further instability episodes. But I think you could really, you could manage this non-operatively. In my hands, I would.
For me, I like things to fit into a very simple diagnostic bucket, and things here just don't quite fit for me. I want more information regarding your clinical examination. And I've been caught out before with low-grade PCL injuries as a result of a hyperextension injury with posterior medial bundle gone. You have a low-grade Lockman, which actually is just because they've got a little bit of posterior translation, and so that firm endpoint is just the normal tension of the ACL. So I think we need to understand a little bit more. Is there asymmetric hyperextension? Is there any evidence of posterolateral rotatory laxity? Is there any posterior translation? And so then trying to get a diagnosis that fits her imaging pattern a bit better from my head. Once I have that, then I wouldn't run into surgery immediately. Again, it would be a functional rehabilitation program, because I don't think my surgery is good enough to really make them significantly better than what they are now. And if they fail that, well, at least we've tried everything, and then it's really the last resort of surgery. But if you push them down a surgical route and it doesn't work out, then you two people are very unhappy, both patient and surgeon.
Yes, Faris?
I'd agree with that. I think there's a separate, similar scenario to what you present here, where there is an ACL that looks just like the ACL you just showed, but they've got a pivot shift bruise pattern. And I think that patient in elite sport is a much bigger dilemma, because I think that's a patient that's proven they've got rotatory instability. And whilst I may rehab them for a while, I've got a much lower threshold. I'd agree with Alan here. I think this is likely to be capsular, some kind of posterolateral rotatory injury associated with it. Manage them. The pain will keep them out of extension for a while and then see how they go, rather than intervening.
So indeed, she has not the bone edema of the injury of ACL. This patient has only bone edema in the front. So definitely is not really, I agree with Robert that probably the ACL is maybe intact or maybe some sprain, but really it can heal. And this is, for me, is rehab first, for sure. Maybe magnetic field. Nobody talk about magnetic field. In this case, I would use magnetic field rehab. Okay, I know you.
Guéri.
Yeah. And if you operate, let's say, the case you just said with bone bruise in mirror, but you find when you operate that the ACL, there are still some fiber of the ACL still there. Do you try to keep it when you do? Yes.
In this case, yes. If I have to do ACL in this type of patient, I try to maintain as much as I can the fibers that are still intact, and I do an augmentation, sort of augmentation.
Agree. It's difficult to measure, but I think remnant preservation seems to intuitively be such a good thing to do. It occasionally gives you an appearance of a cyclops on a post-op MRI scan, which is really irritating. But quite frankly, it's intuitively, in terms of vascularity, in terms of biology, it's a good thing to do.
That's also, if you're thinking down that route, then your graft choice may change, because using a BTB for remnant presentation or preservation is very challenging. It's not impossible, but it's very challenging. And so then you may be forced into using a hamstring graft in a young female athlete, which I personally don't intuitively love doing.
And also consider that if you do the rehab first, it will be return to sports maybe easier, and before, if you do ACL, for sure, in 3 months it can be returned to sport.
Alan, for partial rupture like that, if you do surgery, will you do LET or ALL? Because she's quite young, but no pivot shift. What do you do for partial?
If I'm using a hamstring, yes. But I don't really love using hamstrings, so I'll probably use a BTB in this scenario. If I've rehabbed and they still end up being functionally unstable, I'll use a BTB, but not add an LET, because I don't think it's necessary, because she hasn't had a significant anterolateral subluxation episode.
Okay, thank you very much.